Hi everyone, Felix here, Advanced Clinical Practitioner with Eden Clinic. Welcome to part 2 of our deep dive into the science behind testosterone replacement therapy. If you've not seen part 1, be sure to click the link in the top left corner to watch that first and then come back here for part 2. So, now we have a basic understanding of the science, let's have a look at some common esters of injectable testosterone used here in the UK. The esters we'll be covering will be testosterone undecanoate, otherwise known as libido more commonly, and then a blended ester of 4 esters called sustanon, and these esters are propionate, phenylpropionate, isocaproate, and decanoate. Then we'll also look at testosterone enanthate, cypionate, and propionate. Right, let's start with testosterone undecanoate, aka libido. Now, this is one of the most commonly used NHS TRT preparations in the UK. A standard NHS protocol would initially be a 1,000 milligram starting dose, big dose, with a second dose of the same administered at 6 weeks to achieve rapid steady state plasma testosterone levels, and then injections every 10 to 14 weeks. Testosterone levels are then measured after a further 12 weeks, and injection intervals should be adjusted according to blood results, but they often aren't. Now, what does that look like in terms of reaching that steady state we mentioned earlier? Well, here is what it will look like for a 1,000 milligram starting dose with the next dose of 1,000 milligrams at 6 weeks and then injections of 1,000 milligrams every 10 to 14 weeks. You'll see that on the graph on the screen right now. As you can see, there are significant peaks and troughs, and these swinging valleys can lead to not only the obvious fluctuations in serum male androgen levels, but also negative symptoms in psychological well-being as well, which is reported quite commonly in clinical practice. Now, this isn't to say that libido can't work, it's just that it can be done in a better way that will allow the use of a minimal effective dose with the most positive outcome in terms of symptom resolution and the avoidance of negative treatment effects, but we'll get onto that one later. Now, let's move on to sustanon. As I mentioned earlier, sustanon is a blended testosterone of 4 different esters. Now, the thinking behind this is the hypothesis of the short, medium and long esters balancing testosterone levels over time due to their different half-lives. Now, your immediate Boolean logic-based thinking will get on board with this as it just seems to make sense. However, in clinical practice, you often observe that it doesn't seem to pan out that way. So here is what you can expect in terms of the pharmacokinetics with the esters amalgamated for an overall average over time on an administration frequency of 250 milligrams every 3 weeks. Now you'll see on the graph there we've got those obvious peaks and troughs that can lead to sometimes supraphysiological levels and then subsequently crash back down really quickly. Again, there are other ways this preparation can be used to make it more effective and reduce the negative treatment effects that can sometimes occur, but again, we'll move on to that in another video. So looking at testosterone enanthate and cypionate, the reason we can look at these or discuss them together is because on a molecular level, they're almost identical with just one single carbon atom difference. As a result, they can actually be used interchangeably as their pharmacokinetic profile is so similar. So, firstly, let's look at a common NHS protocol for enanthate, remembering that if we were using cypionate, the graph would have a similar appearance. So here on screen we can see that an initial 250 milligram dose followed by 250 milligrams at week 2, and then every 3 weeks a further 250 milligrams will give us what you can see on the screen now. It's clear to see straight away that the common theme of the other esters under these type of protocols gives the typical multiple peaks and troughs that lead to inconsistent feelings of overall well-being and significant peaks and subsequent troughs in serum plasma levels of testosterone. So we've looked at the sort of medium and long esters. What do we get if we use short esters, namely testosterone propionate? Now there seems to be some discussion about using this ester in the TRT community, and this may work for some, but not others. Well, firstly, let's think about its half-life. It's a very short ester with a half-life of anywhere between 1.5 to 4 days, depending on what source you find. However, what's more important to consider with propionate is its Tmax, or that time to peak plasma concentration level. This is only 4 to 6 hours. Now, this is a very short amount of time for being what's known as systemically active. This makes it a potentially poor choice for TRT as a standalone option, as we're trying to achieve steady state that we discussed earlier. When you're dealing with a medication that has such a short Tmax and half-life, it makes it very temperamental when dosing adjustments are made. You get these big peaks and then these big troughs, which can be seen quite clearly on the example on screen here. Now, some do not get on well with this, as for most we're trying to achieve that steady state. Now, we can try to mitigate for this by administering daily, and then you'll look something like this, and you'll see it on the screen in terms of levels in theory. However, due to that short Tmax and half-life, you may not get these types of results, and when adding in the multiple variables that we all as individual human beings have, it's a difficult compound to use alone to achieve stability. Propionate also has a tendency to convert more to dihydrotestosterone more than other esters, and this can lead to issues in mood regulation and libido for some people. Added to this, the fact that propionate has an extremely high melting point of over 130 degrees Celsius, this can lead to quite significant post-injection pain for some. So you can see why it may not be the best choice for achieving stable male androgen levels. For comparison, testosterone cypionate has a melting point of just 36 degrees Celsius, which makes it a good choice for subcutaneous or shallow intramuscular injection. Although, be sure to check out part 3 of this series, where we'll look at propionate and how it can be used in a novel way that might confer more benefit. We'll touch on that later. Right, I think we'll wrap it up for part 2 there, guys, as that was a look at the different esters and how they tend to be commonly used in standard UK NHS practice. Be sure to look out for when we release part 3, where I'll be discussing individual esters and looking at the action within the body when used in different treatment regimes in a private practice setting, and why some perhaps may be a better choice for some people more than others. As always, if you've enjoyed the video, please hit like and subscribe, and make sure you hit the bell notification so that you don't miss any of our uploads. See you in the next one.